Dr. Victory, if I tell everyone who you are, then I'm going to probably read some really old profile of you. So I think the best way to do this is for you to tell everyone who you are so that we get relevant information, new information.
I'm a Canadian trained OBGYN. I did a subspecialty training in reproductive endocrinology and infertility in the US. And I like to figure out what's wrong and help fix it instead of just endlessly plowing people through IVF. So we're really about diagnosis, customizing protocols, individualizing care. We focus a fair bit on endometriosis, but we like to be at the cutting edge of things. So we really try and use the science, improve the patient care experience without pushing people into things that they don't necessarily want or need.
Actually, I'm glad you brought up the endometriosis thing. There are going to be some questions about that, but I have a question. I
Yeah.
feel like it's become much more relevant or popular, or I don't know, like you weren't hearing about this as much 5, 10 years ago. So I'm curious, do more people have endometriosis or is it's getting diagnosed more?
I think it's probably a bit of both. I think the prevalence is increasing, but there's no question that people are waking up to it more and more. And women are finally being heard a bit more than they were before, which is very important. For way too long, doctors have said, oh, your pain's normal, or it's normal to have painful periods, or it's fine that you're having painful sex, or those kinds of things. And now, slowly, granted, nowhere near where it should be, but slowly people are realizing, oh, it's not normal to have severe pain when you have intercourse. It's not normal to suffer when you have a period. And maybe there's something wrong. Maybe we need to pay attention to this. So the tide is slowly shifting, but it's taking a very long time. And admittedly, the structure, the infrastructure is really bad for it. So gynecologists are all over busy, especially if you're in Canada, as I am. We're overworked, we're underpaid, we are woefully deep into all of the patients that we have. So you don't get a lot of time to spend with the patients. So they're in, they're out, and you're just trying to get them temporized or better. And then in the fertility world, the problem is most fertility clinics just want to make more money. And they make more money when you do more IVF. So they're not necessarily focused on providing you with optimized care or personalized care. It's a very cookie cutter approach because a lot of them are owned by venture capital, private equity. And so their mission is different. Their mission is to make money. And so if you have endo, that just means you're doing more IVF, which is sadly a good thing if you're a fertility clinic. So we don't work that way. And I know some other clinics that don't work that way, but it is becoming more and more common to kind of see that. So the infrastructure is bad for helping women with endo. And we need to work to improve that.
I assume that means you're not selling out to venture capitalists or private equity anytime soon.
I'm owned by me and my wife and my 3 kids, and that's it.
Okay.
So, no, I've had offers to sell for more money than I ever imagined possible, but I'm a religious guy and I believe I'm here to help people. So I can't do it because I'd be selling out and those people that need the help wouldn't get it. And I just don't think it's fair for people. So
Well, it's very kind. And also, I imagine you'd be bored, possibly, if this is your
I'd be very
full.
bored.
Yeah,
I am a workaholic. This is true.
kind of figured that. Okay. All right. So
Yeah,
let's get into the questions. So,
sure.
for a 44-year-old woman, would you advise trying to optimize hormones naturally first or moving to medication-based treatment if fertility has been an issue?
So I'd advise a long chat with a reproductive endocrinologist. So we need to do the math for a 44-year-old woman so she understands the math. And then once you understand the math, you can understand the choices better. So at 44, close to 90 to 95% of the day 5 embryos you produce will be genetically abnormal. Doesn't matter if it's natural or IVF or IUI, you're going to make 90 to 95% of your embryos be abnormal. Let's be conservative and call it 90%. So that means you need 10 embryos to make it to day 5 in order for you to have one that's normal. And so, in order for you to have 10 embryos, you're going to need to start with somewhere around 20 to 24 eggs. So, if you're trying natural, that's basically 2 years of trying before you'd be successful potentially, or somewhere in 2 years. And then, if you're trying IUI, you might shorten that to about a year. And if you're trying IVF, you're talking about needing somewhere between 6 to 10 rounds of IVF for the average 44-year-old. So these are huge numbers. Now, there are variations. If you have extremely strong ovaries, you'll do better. If you have amazing genetics and your partner's sperm is incredible, you'll do better. But you're still going to need a lot of treatment or a lot of trying in order to improve chances. So if you're going down that path, then certainly I would recommend doing something that's faster. And so going into treatment, whether it's IUI or IVF or even timed intercourse, will be beneficial for those patients. But you got to go into it eyes wide open, because a lot of women enter into it thinking, I'm going to get pregnant, only to find out it didn't work. And now they're looking at donor eggs. So you have to go in understanding the math. As long as you understand the math, you have lots of choices.
I have a follow-up question to that. You hear these stories of like the 46-year-old naturally getting pregnant, are very rare, but you hear it. But you don't really hear someone with IVF unless they froze their embryos earlier, eggs earlier, or if they used a donor doing that at 46. Why? What's the discrepancy about there?
I mean, people doing IVF need to try many, many times before they're going to be successful if they're older. People doing donor, I mean, it's easy, right? Like our donor success rate's in excess of 90%. But when you're trying IVF on your own, again, depending on your age and the outcomes and the things that you're looking at, the chances of success can vary widely. Egg donor, you're going to get a 90-95% chance you're going to walk away with a baby. But a non-egg donor situation, it all totally depends on how young you are, how old you are, what's your partner's health like, what's your BMI, do you take vitamins, do you eat a healthy diet, are you smoking, drinking, drug using? There's so many factors that go into it which alter those outcomes. And then, you hear occasionally of people that are successful, but you're not hearing about all the ones that aren't, because they're not out there saying, I wasn't successful. Shame, embarrassment, guilt, failure, like there's a whole psychology to this. So people are only hearing about I got pregnant and I was 42, but you're not hearing about the 90 other women that didn't get pregnant.
Just luck, genetics,
It's,
luck.
it,
Because you hear about I don't know if this is true, but a friend got pregnant naturally at 50, which I feel like if you go into IVF, you're not going to get anything.
No, I mean, natural, again, like if it works, it works. But keep in mind, we know that only 2% of people that need IVF are actually accessing IVF. But you've got literally billions of people at home having sex, right? So
It's interesting. Yeah, 2%.
yeah. So, I mean, there's a vast difference between the people that are getting pregnant naturally, because there's so many trying, you're going to
That's a good
get one,
point.
right? Yeah. Whereas
Numbers
the
game.
people doing IVF is like a really small number of
Right.
people.
And I imagine if they come in at 50, doctors are gonna be like, I'm sorry, can't help you.
We still will do whatever the patient wants, but I have that same discussion I just had here
Right.
and say, look, you're like, your chances are very low. You want to try, great, I'll help you try, but you need to go into it eyes wide open. I'm not going to sell you a story and say, oh yeah, try IVF, we'll see what happens. No, I'm going to sit you down. I'm going to tell you this is almost impossible, but if it's really important to you, I'm happy to support you. I'm all about autonomy, but again, understand what you're getting, right? It's like going in to buy a car. If you go in to buy I don't know, a Mercedes, and they're actually selling you a Yugo covered in a Mercedes body, you're not getting what you're paying for. So people need to know what they're actually getting. And again, fertility places sometimes do a great job of that, and many times they don't do a great job of that.
Okay. Next question, which I will also answer with you, but I'll let you answer mostly.
Sure.
Someone said, what do you recommend when one partner is open to trying naturally? We've tried for 9 months and isn't open to fertility treatment. I'm a 37-year-old female, so you could take the medical side. I'll take the other side. Couples therapy. Okay, now go ahead.
Okay, well, I mean, I think that women are incredibly intelligent, generally speaking, much, much more intelligent in emotional sense than most men are. And I think that there is a lot to be said for communication. So I think a woman who wants to sway her partner, assuming this is a female, and basically convince him that this is the path they need to go, I think you use that emotional intelligence, like lean slowly. I mean, guys are not immediate responsive, right? We get defensive and we get our back up against the wall, and then it's impossible to change our mind. Not that that's right, but it's just typical. And so I think that what a lot of women can do, and often we see this, is bring their partner around to that understanding. Let them know how much of a burden it is on the woman. Let them know the emotional toll it's taking on them. Let them know that they feel the guilt, they feel the shame, they feel the pressure, the clock is ticking, and that they're not going to be happy about this a year or two down the line if it doesn't work. And they're going to start blaming. And I think slowly, when you bring in that into it, the guys tend to turn the corner. When all else fails, I usually just tell women to stop having sex because there are very few guys that will
That's a good one.
reject whatever a woman wants if they can't, get what they want on the other hand. But I think realistically, there's a lot of good options for women to use that innate emotional intelligence to kind of bring things around to where they want them to be.
Do you find that men sometimes come in and say, "Oh, it's not me. I don't need to check my sperm," or no, that's not a thing?
Not sometimes, all the time. I mean, that's
Oh.
common, right? And then even when they do find out it's them, it's difficult getting them to give up smoking,
Mm.
drinking, weekend warriors with the boys, and marijuana and all the bad habits that they have that are contributing to terrible sperm quality. You tell a woman, you need to go take some vitamins and I need you to exercise and please lose 20 pounds. And they are like, they're on it. They do it. They're committed. They're all in. You tell a guy like, stop drinking 24 beer a week. And they're like, well, my buddies did it. They were fine. I'm like, well, you're not your buddies. And that doesn't work, right? So it's very difficult to get through to the men. Very, very challenging. There's no question. But as a physician, there's like this distrust and this
Mm.
barrier because they want to hang out with their buddies and listen to their buddies. And their buddy got their girlfriend pregnant 3 times and he was smoking and drinking and having weed and all this stuff. But when it comes from their partner, it's a lot harder to reject or refuse. And that's why I think that's a way better way to do it than through the
Got
doctor.
it. Especially if you're holding out, like you mentioned. Okay, next question. What IVF protocol would you recommend for someone with diffuse adenomyosis, suspected endometriosis, and fibroids using embryos frozen at age 37? I'm 47 years old with an AMH of 1.6. Should I attempt another egg retrieval? I'm not open to donor eggs.
I mean, if you have a sufficient number of embryos and they were genetically tested at 37, no, I would definitely not make more embryos at 47 because your chances of success are very, very low. What protocol would I recommend? I need to know more details about that. So, how big are the fibroids? Where are the fibroids? You may need surgery. Larger fibroids are proven to be detrimental, so they require excision, especially if they're more than 4 or 5 centimeters, or there's any indentation of the inside of the uterine cavity. So in those circumstances, patients need a surgical consultation or at least discussion with someone like me who does the fertility but also does the surgery. From the standpoint of endo protocol, we actually have a fairly well-known endo protocol that we designed where we address the hormonal aspects of it, the natural aspects of it, and the immunological aspects of it. So we have suppression therapy to get the estrogen levels really low. We use super high dose progesterone. We measure the progesterone levels because endoadeno patients are progesterone resistant. We use a lot of natural supplements to kind of boost the body's natural ability to quell the endometriosis. And then we use an immune protocol because there is a lot of immunoreactivity in endo and adeno patients, and you need to calm that down. In order to do that, it takes some pretty strong medication. One of the drugs we use is an anti-rejection drug, like the stuff you give people that are getting organ transplants, because an embryo, for all intents and purposes, is a foreign organ for half of it, right? Like half of it's like you, but half of it's like your partner. And your body doesn't recognize that half. So in a lot of cases, we have to kind of calm the immune system down to let it know this is going to be okay. Don't go into attack mode every time. There's different ways to do that, but there's some really good medications and protocols that help us with that.
Okay. How long does it typically take to rebuild healthy uterine microbiome bacteria after antibiotics before an embryo transfer?
I'm rapidly becoming a non-believer in having people give antibiotics before embryo transfers. In fact, we've done it for years, but we're going to take it off of our protocol. The problem with the microbiome is, first of all, it is very difficult to establish a normal microbiome in women. Very difficult. It's easier in guys, but in women, it's like really, really challenging. So first, you have to normalize that microbiome, and then you got to maintain it. A lot of places are doing things like a endometrial biopsy. They get a sample, they look at the number of CD138 cells you have, and they go, oh, you've got endometritis. Useless test, by the way, totally useless. Never do that. And then they give you doxycycline. Doxycycline is an extremely effective drug at killing all of your good bacteria, the lactobacillus. What is it not good at? Killing probably about 80% of the bad bacteria that are there, most of which are what are called obligate anaerobes and don't respond at all to doxycycline. So now what you've done is killed your good bacteria, which gives the bad bacteria more space to grow. And they're looking at it going, party time, let's invite our friends, let's grow like crazy. And so you've actually made things worse. The answer to that question is, I don't advocate for giving people antibiotics right before an embryo transfer anymore. And if you are, it has to be targeted therapy. So you need to know what bacteria you're treating and then treat those with the specific antibiotic that kills those bacteria. And then you need a recheck. And once you've established a normal microbiome, for the love of God, don't take any antibiotics because that'll ruin everything all over again.
Okay, good to know. Someone asked, can you explain DOR, diminished ovarian reserve, and how it's typically evaluated and managed?
Well, that's a great question. Diminished ovarian reserve is a situation in which a woman's ovaries are not capable of producing as many eggs as we would like or one would anticipate. There are various definitions and there is not universal agreement, although there's something called the Bologna criteria and people kind of use that more or less now, but no one entirely agreeing on what defines someone as having DOR. The general gist of it is that at a given age, you're producing less eggs than the average number of other women your age. You can measure that with something called an antral follicle count, where we measure the number of eggs that you have or count the number of eggs you have on ultrasound. A lot of people use a hormone test called AMH, which stands for anti-Müllerian hormone. FSH is kind of a weaker test, but it can also substitute in there sometimes as well. But the main kind of ways to figure this out are either your AMH, your antral follicle count, or how you've responded in a previous cycle. So if I take the 35-year-old, who I'm anticipating on average is going to make me about 15 eggs, and she only makes 6, she probably has some degree of DOR. There are different ways to kind of measure it, but that's essentially what it is. It's the inability to produce the anticipated number of eggs for your age.
Women with suspected endometriosis or adenomyosis always need immune testing. I will also be having a laparoscopy, whoever's asked this question.
You don't always need immune testing. We know how to treat the immune problems, intralipids, steroids, tacrolimus. Will you benefit from immune testing? Sure. Do you have to do immune testing? No, it's totally optional. And just to go back, because that last question asked, how do you manage DOR? DOR is unfortunately a one-way ticket. There is no way to manage DOR. So there's some things we use for priming, some natural, some medical. So testosterone, DHEA, rapamycin may work. Hyperbaric oxygen chamber therapy seems to be reasonable as a consideration as well. We use human growth hormone. So there's some of the more medical things we can do. Naturally, there's lots of supplements, coenzyme Q10, NAD+. There's some other ones like NAC and so on that might give you a little boost. Vitamin D is huge, very important. Fish oils, melatonin. But there is no good way to manage DOR. It's a one-way ticket. You're headed towards menopause. So it's basically hurry. And that's the only way to get over that hump of DOR.
Is there any correlation with DOR and the quality, or none at all?
That's the billion-dollar question. I sat through a very interesting talk in New Orleans at the American Society for Reproductive Medicine, where people were discussing that. And the majority said that no, there isn't. But quite frankly, I think they're all out to lunch and they were wrong because they want to, again, drive more people into doing IVF. There's no question that the older a woman gets, the harder it is to get good quality embryos, the harder it is to get genetically normal embryos. And we know from well-done research that a genetically normal for a blastocyst from a 44-year-old does not have the same chances as a genetically normal for an embryo from a 35-year-old. They're wildly different in their success rates, probably 30, 40%, if not more. So there must be something integral to the quality of the egg that comes with the fact that your ovaries are getting weaker. Now, whether that's true in a 35-year-old who has a weak ovary compared to a 35-year-old that doesn't have a weak ovary? That's a tougher question. My personal belief, yes, I do think there is compromise, but no one's done that study yet.
I did not know that about the 4A PGT from one age to another, which reminds
Oh,
me of
yeah.
a recent study that just came out in the Fertility and Sterility with ASRM. And they said that even with donor, a uterus matters. So, like the older
Yes.
the uterus, interesting.
Yeah, that's right. So women that have an older uterus have lower chances, even when they're using donor egg.
Do you know why?
Blood flow is probably number one. Endometrial aging is number two. Receptivity. Your body's looking to shut down. It's not looking to support pregnancies. And then exposures, a lifetime of chemicals and toxins and environmental exposures and infections and heat and immunological changes, plastics, all that stuff. Like it takes its toll.
Okay. Next question. For recurrent pregnancy loss, how do you decide between Victory Panel 2 versus an RPL Fertility panel? Is this Victory thing your thing?
So, well, Fertility and I have a very good relationship. So what ended up happening was initially they had separate packages, and I realized very early on my clients were going to want to do both. So I created Victory Panel 1, which is for recurrent implantation failure, and Victory Panel 2, which is for recurrent pregnancy loss. So the fertility testing has only one extra test, which they just started to include like very recently. And that's the only thing that's different between Victory Panel 2 and the fertility. It's an interesting test that they've developed, but there's absolutely zero proof for it. Like even they're saying we're doing it as an experiment, and it adds to the cost. And I already hate the fact that it's expensive. So I haven't jumped into that yet. Maybe we will eventually. We also don't know how to treat what they're finding. So even if you have it, we don't know what you have to do for it.
Okay. Next question is, what is your take on conventional fertilization? I've had 2 egg retrievals, but poor egg quality seems to be limiting success. Also, what is the best first step for diagnosing endometriosis? Is it Receptiva testing or something else?
So if they're talking about conventional versus, we don't do conventional IVF because we have very high ICSI success rates. So I make our team ICSI every single case. Is there an advantage to conventional? No, there's absolutely no advantage to conventional. Is there an advantage to ICSI? Yeah, you're going to get more fertilized eggs if you work with a lab that has very high success rates. Otherwise, there actually isn't one, and there isn't an advantage. And if you're being charged for it, we don't, then you're at a disadvantage potentially. So if you're going somewhere where their ICSI success rate is, I don't know, 60% on average, and they're charging you $1,800 to do it, that's a waste of your money because conventional's got the same success rate and you're not paying for it. But if you're getting it for free, like we just have a package for our IVF. You want ICSI, great. You don't want ICSI, you can refuse it, but you're paying the same price no matter what. So we just include everything in our packages. There's no like nickel and diming people. And that way we just do the best for everybody, no matter what's going on. The second part of the question was Receptiva or other tests. Receptiva is useless. It's proven useless. So please don't waste your money on that. There's actually a great study from Israel showing that if you ask someone 23 questions, you get the exact same sensitivity and specificity for detecting endo that you do by paying $750 for the Receptiva test. So it's completely useless. Don't do Receptiva. And I love the guy that created the test. He's a really nice guy, but it's a useless test.
Didn't he retract also in like a...
Not that I'm aware of. They still
I thought he
market
wrote
it.
something about it.
Yeah, it's a useless test. It doesn't work. Is there a good test for endo? There are a lot of companies right now claiming that they've like got a saliva test in Europe. They're claiming very high success rates in detection. They've got another test that was developed here in Canada. It came out and then they had to retract it because there was no proof it worked. Like there's a whole bunch of these tests available, but at the end of the day, no one has any test that is proven to be that sensitive or specific. So the only test for endo is laparoscopy.
Maybe it's EHR that I was thinking about, or ERA, that the retracting of the ERA.
Yeah. So ERA reduces your chances of success by 13% and is incapable of actually detecting receptivity differences. And they've proven that in a very well done randomized controlled trial. So nobody should be doing the ERA test. It'll actually reduce your chances.
Okay. I know that some of you guys are asking questions and I will try to get to them, but I do want to touch on this question since it was the person who talked about the ICSI, so, or the egg quality. She
Yeah.
said, this is my question. I'm 35 years old for context. My doctor theorizes that my poor egg quality can't handle ICSI, which we've done for our 2 egg retrievals. That's why I guess she was thinking maybe conventional.
That person probably needs to call me. There are ways to improve egg quality. It's not a guarantee, but like naturopaths are really great at that. Not physio. Traditional Chinese medicine is really good at that. Vitamins are good. Sometimes it needs a change in your diet. Nutritionists can really help you with that. Like there are all sorts of approaches that are great that can really improve how a woman's going to respond. And the protocols are important too. So we get a lot of women with DOR, and then they're put on like mega doses of medication to try and get more eggs. We know that that's harmful to the eggs. So nobody should be doing that. That's a catastrophe. So your protocol matters. It makes a huge difference. And the prep leading up to the protocol matters. There are social media fertility specialists who constantly make fun of taking supplements and vitamins and stuff. And then day after day, there's more publications showing how important it is to take supplements and vitamins. So, it's really important to actually optimize your health before you go into treatment. It's also important to have a protocol that's appropriate. If they're not using the right dosages or the right medications, if they're giving you birth control ahead of time, if they failed to give you human growth hormone and testosterone and the NAD plus and the coenzyme Q10 and all these things, double trigger activation, you're not going to do as well. So those are the cases where I often recommend get a second opinion. Find an RE that you trust or that's at least known for providing honest responses, and talk to them about your protocol and see if it makes sense. A lot of times I get people getting a second opinion from me, and like I genuinely feel bad because I don't want to throw my colleagues under the bus, but you literally, I don't know what to say to them because it's like, how the hell did you even think that this was ever going to work? This clearly was never going to work. So in those circumstances, we generally try and encourage the patients to find information or knowledge or another opinion that can help guide how they're going to do.
So even for donors, do you use ICSI?
Yeah,
Okay.
every time. Yeah.
Got it.
Yeah.
Okay, next question is, how long do you typically recommend suppressing endometriosis if stage 3 endo was surgically removed 1 year ago? After LIT, what is that, like lymphocyte immunotherapy or something?
Immunization therapy, that's right.
Okay. Should you try naturally or move directly to IVF if you're a 40-year-old? So how long suppressing if stage 3 had surgery a year ago and LIT?
So in our protocol for someone with stage 3, we would probably suppress you for 3 months, Lupron and letrozole. And please remember that Lupron alone is useless. It has to be Lupron and letrozole. So that's how long. If it wasn't like really bad stage 3, maybe 2 months, but it would have to be 2 or 3 for sure. In terms of when I jump into IVF, I mean, these are really personalized decisions. I would need to meet you, get your history, find out what you're looking for. Do you want 1 baby? Do you want 3 babies? Do you want 2 babies? How strong are your ovaries? How good is the sperm? Like, these are all questions that go into the calculation of what should you do. I'm not a big IVF pusher. I believe in it. I love doing it, and we're very, very good at it. But I don't force it on people. I want people to understand the math and then make an informed choice for themselves. So I would need to learn about you, give you all the information you need to determine, what the outcome is going to be, and then you decide. There's a really good app, an incredibly good app called Fortune-IVF. So Fortune-IVF. It's free. You plug in like 5 different parameters: your age, your BMI, your AMH level. I forget the other 2. There's 2 other things you pop in there. And it actually tells you how many cycles of IVF you're going to need to get to 3 genetically normal embryos. So, if it tells you you're going to need like 10 cycles of IVF, ahead of time, this is probably not medically or financially practical, or emotionally for that matter. And so you may want to try naturally, because for you, the next step may actually be so there are ways for us to help guide patients. It's interesting. I brought up this app at a fertility conference, and I was on a panel with the 2 other doctors, and they immediately got panicked and said, well, that's only applicable to one subset of patients, and it was the ones they studied. And I was like, actually, it was done on like 14,000 people, and then they validated it in a prospective trial. So no, but again, I don't want to throw people under the bus, but there are really good tools out there now with AI and all the knowledge that we have where we can actually gauge for you ahead of time, this is what it's going to take. And then you make a decision based on the knowledge.
I have a question for you. Oftentimes, if I'm working with someone and they are being suppressed, also their mental health plummets a little bit. Is there anything you recommend or do for that?
I send them to you, so that's good. Psychologist, social worker, we have an online program that we use, any kind of mindfulness therapy, do couples things. I always tell people, like, you have value as you. You don't need to have a baby to have value. Yes, it's important. Yes, everybody wants one. I'm 100% supportive, no question. But as an individual, as a couple, you have value. And you don't need to feel that you don't have that value unless you're, with a child. I try and talk people through it, but clearly that's not my area of expertise. So I defer to
So
the
there's
expert.
nothing when they're like on suppression that can, like, I don't know, supplement or
Medically speaking, here's a drug or here's a pill or
yeah,
something
like
like that.
anything. No. Okay.
No. The suppression protocol we use is hellish. It works and it works very well, but it's horrible. Like, it's evil. So,
Yeah.
Again, I warn people in advance, this is going to be torture.
Okay. Next question's a bit of a mouthful, and you might end up saying, I have to see this person, but here we go. What would
Okay,
you
I better take
suggest?
notes. Hang on. Okay, go ahead.
What would you suggest for an endometriosis patient who has had asynchronous follicle growth during IVF stimulation with Menopur 150 and Recovel 12? My AFC was 14 and my AMH was 1.7, then 1 2 weeks later. Am I considered DOR? I only had 4 mature eggs in my last retrieval.
So I would need to know what her priming was. I would need to know if your priming included testosterone, human growth hormone, DHEA. Those tend to sink the follicles, so that can help. I would need to know how long they stimmed you for as well, because that can make a difference. Did they put you on birth control pill ahead of time?
She said I was on Visan for 2 years, no priming. That's 9 days stim.
So that's too short a stim.
33 years old.
Yeah, so that's too short a stim, number one. Number two, I wouldn't go right off of being on and into a stim immediately. I'd wait a little while because it is suppressive. And then the other thing that can be added in there is the consideration of doing something called duostim. So you do your follicular phase cycle where you have your period, you stim, you do your retrieval, and then you wait 5 days and you start another stim. Mariam has a very Persian last name, so I'm Persian as well.
What is Visan?
It's a type of progestin which is very effective at calming endo.
Okay, next question. I've had 5 miscarriages. All testing and genetics are normal, but I suspect microclotting issue. How would that be evaluated? Is IVF necessary if you can get pregnant on your own but can't sustain pregnancy?
Recurrent pregnancy loss is a big deal. There are many different things that can factor into it. Shape of your uterus, vitamins, thyroid and other hormones, your microbiome, your immune system, and then thrombophilia. Genetics is a huge one. Some people have genetic abnormalities. And something very new that very few people even know about is that you can now test people for whether or not they have genetic defects in the eggs or the sperm that are permanently going to prevent you from ever having a baby. So as an example, there are people who have what we call essential gene variants. So there's 22,000 genes in the human body or the human genome, and 11,000 of them are essential. You've got a mutation, you don't exist. So you can get those mutations in the sperm or the eggs. The person's normal, but their sperm or their eggs have problems. And so when they go to make a child, that essential gene variant's getting passed on, and it's never going to work. So you can actually test embryos for that now and find out if they have that. So there's a lot that goes into this, and that's just on the female side of things. On the male side, there's male genetics, sperm DNA fragmentation, sperm aneuploidy, oxidative reductive stress. We got all sorts of things we look at in the guys now too. So you need a true expert these days, because what I often find, and this is horrifying, is that people go to a fertility specialist and say, I'm having recurrent pregnancy loss. And they go, okay, we're going to do IVF, which doesn't help one iota at all with improving your chances. And then if you're lucky, they'll do PGT-A testing. So at least you know it was chromosomally normal, and that might reduce your chances of miscarriage. But ultimately, the reality is unless you actually know what's wrong, you can't fix it. So you have to know what's wrong first in order to fix it. So there's a lot of diagnostic workup involved there.
Are you a big proponent of PGT, like even if it's like a very young person or a donor?
So we just started our own PGT-A lab. It's about 20 feet that way. And so I'm a believer in it when it's appropriate. So when is it appropriate? It's appropriate if you've had multiple previous failures. It can be appropriate if you've had multiple miscarriages. You want to make sure the embryo is normal and you're doing IVF. It's appropriate if you're over the age of 35 for sure. And then for people that have a lot of embryos, like, you get these young people, all of a sudden they're PCO, they make 20 embryos. You don't want to be going through 20 embryos before you find out which ones are normal. So sometimes it's appropriate in those circumstances. Who is it not appropriate for? Your average 25 to 33, 34-year-old who's got like mild male factor and they're producing a handful of embryos. They don't necessarily need it. Is it a bonus? Sure, but it's not cheap. And so it all depends on, whether or not they can afford it and what kind of financial structure is in place to help them.
Someone who has PCOS, they have a lot of eggs, but are the quality typically decent?
Compromised.
Compromised.
Yeah, it's definitely compromised. We know that.
Okay. Is there a strict cutoff for uterine lining thickness before transfer?
The newest study, very new, about 2 months ago, suggested that we should be using a even higher cutoff than we normally did, which is 9 millimeters instead of 8 millimeters. We know that once you go below 7, there's like a drop off in the success rate. So 7's like a hard floor. But I mean, there are people that just don't get more than 7. They'll get 6.8 or 6.5, and you have to transfer into them. I have one lady once upon a time who had a genetic abnormality, and she managed to produce one embryo only that was genetically normal. And that was it. And we tried her, and no matter what I did, I could not get her lining to thicken more than 3.5 millimeters. It was hopeless, just terrible. And I pleaded with her. I said, you need a surrogate. This is not going to work. And she said, nope, try again. So we tried everything. We got her to about 5.5 millimeters eventually. Viagra and aspirin and vitamin E and this, that, and the other thing. And then she said, yeah, this is it. It's me or bust. And I was like, okay, you do you. So we did it, and she got pregnant and had a baby. So sometimes it works, but we try not to do it below 7. And
What's
you
too
should
thick?
aim for 9.
Is there a too thick?
Yeah, over 14, it's too thick.
Do you offer adjunct procedures or treatments like scratch, PRP, Neupogen, and when should they be considered?
We offer many of those. I will do a scratch, but it's useless and it's horribly painful, and it's the most controversial thing in all of fertility. So I haven't done one for, I don't know, 12 years or something like that now. I do all the rest: Neupogen, PRP, HGH, HCG washes, intralipids. We do a lot of stuff. When is it appropriate? Previous failures, very low number of embryos, patient with a known problem, like you've got immunological issues, anything like that. I mean, there's lots of different indications for it. Again, we don't push it on people. We're more like, here's a menu of options. Here's why I think it might benefit you. Are you interested in these? And if they say yes, we do it. If they say no, we leave them alone.
Okay. I'm going to try to get through a couple of the chat questions here. Do you think slow development of embryo 4 cells on day 3 caused by egg quality or sperm?
If it's in the first 3 days, most embryologists will tell you it's egg quality. And if it's in the next 2 to 3 days, most of them will tell you it's sperm quality. So if you're a 4 cell on day 3, that's more likely to be an egg quality problem than a sperm quality problem. Again, science is not math. It's not like 1 + 1 = 2. These things have so many variables in them. You've got to really look at each one, but that's the gist of it.
Okay. Next question. Is there such a thing as timing window of implantation that can be causing failures? If so, and ERA is not recommended, how do you get the timing right?
That's a great question. If you figure it out, let me know. We can both be, multimillionaires. I don't know the answer to that. There is definitely a window of implantation. It's roughly somewhere in the neighborhood of about 8 hours. That's what they think. But the problem with that is we don't know where those 8 hours are. And there are many studies which show that you actually have about 24 hours to pull it off. So it's really hard to know what's right and what's wrong in that circumstance. I can tell you categorically that there is not a single valid endometrial receptivity test out there. None. There are none. And the era was the worst of them. We just don't use that. We go based on the science. The science says you got a day 5 embryo, put it in after 120 hours of exposure to progesterone. You got a day 6 embryo after 144 hours. So that's what we do.
Okay, next. What can be done to improve or prepare for effective implantation? 39-year-old woman, first transfer with 5A embryo, history of fibroids and endometriosis, which were addressed via mastectomy last year. Any good supplements to take? Does one really need to rest? And if so, for how long?
Optimize your diet, optimize your stress level, optimize your weight, take loads of vitamins and supplements, especially for endo. Again, I would advise doing an endo protocol, whether it's ours or someone else's. And then I would focus on doing whatever stresses you the most. So there's this interesting study from California where they took people and they randomized them into hop on the bed, here's your embryo transfer, wait 15 minutes or 10 minutes, and then get off, nice and calm, everybody relaxed, whatever. Or here's your embryo, get the hell out of here, you're done. And interestingly, the group that did the get the hell out of here, you're done, had a higher pregnancy rate. But if you've ever been to California, people don't eat, they inhale their food. Everything is a rush, right? So I think that culture leads to people feeling more comfortable just being busy all the time. And so I think it's very deeply personal. If you're someone where going back to work is going to distract you and you're going to be better off that way, and you're not going to be on Google looking up every twitch that you had and what does this mean, go back to work. You don't need to rest. If you're like, hey, I want to put my feet up, I want to watch a couple of Netflix comedies, I need my calm, take some time off and stay home. It's very personalized. There's no like one size fits all.
I was working with a gestational carrier, and the doctor had her on 10-day bed rest with Valium after her transfer.
So all I can tell you about that is that there's absolutely not a single shred of evidence to support that approach. Literally none. And the embryo implants in the 24 hours. So it's either stuck or it's not stuck. The rest of the 9 days, you're like, twiddling your thumbs, right? That's useless. So, I don't know what justification they had for that. There is none. There's literally none. There's no scientific validity behind that approach.
Yeah, I felt for her. What is the purpose of aspirin during FET? What if someone is allergic to
non-steroidal anti-inflammatory drugs? Yeah, the purpose is improving blood flow, reducing microclotting, and reducing inflammation. So it has a triple purpose. What do you do if you're allergic to NSAIDs? You don't take aspirin. You could take Plaquenil. It's not quite the same, but it does have some of the same benefits. So you could try Plaquenil if you're allergic to NSAIDs. But at that point, I'd actually talk to someone who has reproductive immunology experience, myself or anyone out there who does that, because we can kind of guide you on what you should do. And most of the time in that situation, we'd be asking you to do some testing.
I have one more from the chat, and then I have one of my own medical and two fun ones. So it's your Persian Miriam girl. She first wants to thank you. And then she said, I've got a moderate OHSS after retrieval last Friday, and sadly, my doctor is not in the country. When should I be concerned, and what can I do about it? Would it worsen my endo?
IVF inherently worsens endo. OHSS won't worsen your endo, but IVF does. I'm surprised you have OHSS, and I'm sorry, it almost never happens anymore if they use the right protocol. So I'm kind of surprised about that. But if they use the right trigger, you shouldn't be getting OHSS. We get like less than one a year now. It's super rare. But it's not going to make your endo worse. It's going to feel uncomfortable, and it is a little bit dangerous. So make sure you're seeing somebody and they're addressing the concerns. You need fluids, you need protein, you probably need to be on a blood thinner. Talk to your doctor, make sure you're getting appropriate care.
How long does it last if someone has it?
Depends on how bad it is. I mean, I've seen it go on for 10 days and I've seen it go on for literally overnight. So it all depends on how bad.
Okay. So my question is with grading. So, you get the PGT-A, and then, some areas are like, yes, the grading really matters. And some are like, doesn't matter so much. And then also each lab probably has their own grading a little bit subjectively. So how do we know when grading is really important versus not?
Well, we know from the science. So the science shows that when you look at genetically normal embryos, euploids, the grading matters. There's a difference in success rates based on the grade of the embryo. Now, A-graded embryos and B-graded embryos, tend to do roughly about the same. There's about a 5% difference if I remember the study correctly, but C-graded embryos are not nearly as good. There's a big gap there. So once you start seeing a C in your nomenclature of your embryo, that's not as good.
And how consistent are the different labs? Most would say the same C is same C.
No. Certain clinics will instruct the embryologist, to upgrade or downgrade the embryos based on whatever outcome they're looking for. Reputation, you're going to upgrade them. Success rates, you're going to downgrade them because you only want the good embryos, right? So it all depends. And I think there's about 5 different grading systems, and there's no agreement on which one to use.
Okay. Yeah. Okay.
And keep in mind, it's totally subjective.
Yeah. I feel like it's kind of hard when people hear the grade. Okay. So here are my more lighthearted questions. If you had to swap careers for a month and you were already an expert at it, what would you choose?
If I was what for a month?
To swap careers for 1 month only, and you're an expert already, so you don't have to train or anything.
Lawyer.
Oh, interesting. Like a court one, like on trial, like that one?
Yeah.
Not like the paperwork, doing the paralegal work. Okay. Well, like a criminal case or like a civil?
I don't know about that. I probably wouldn't do criminal because I could never defend someone guilty.
But you can go after them.
I would happily go after them. Yeah. Yeah, I'd be a lawyer. I actually was torn between becoming a lawyer and a doctor, and I made my parents decide because I couldn't decide.
Oh, okay.
Yeah. My dad eventually said, after like 4 hours of arguing, they kept saying, no, we're not going to decide. And my dad finally said, okay, listen, I hate all lawyers, so I want you to become a doctor. And I became a doctor.
Wow.
And the irony here is I have 3 children. My youngest is a girl, and my daughter is in medical school. And my older 2, obviously, are boys. And one's a lawyer and the other one's in law school.
All right. Well, there you go.
Yeah.
Maybe it's genetic.
I don't know.
Okay, last question. Do you go to bed with your email inbox at 0, or are you one of those with thousands of unread messages?
I can't go to bed with my email inbox at 0. I literally had to hire someone just to go through my email. That's her job, is to go through my email, because I get somewhere around 200 emails per day.
Okay.
So I finish all my emails by about midnight. And by the time I'm ready to go to bed,
there's more.
Yeah.
But so for the most part, you clear it.
I usually will clear it. Yeah. Yeah.
Okay. Can I ask you, dye? You hate dye, yes, right?
Yes.
Okay. And how often? Because it's so black.
Just recently, which is why it's so black.
Oh, okay. Got it. Mine's all natural, but I can't dye anything else because of that.
Oh, there you go. Yeah, but I'm quite convinced there is a very substantial age difference between you and me. So
perhaps mine might start getting to this color over here with the on the side. All right. Well, thank you so much. I really do appreciate you coming. You answered some very tough questions, I have to say. So appreciate it.
I'm always happy to do it again. If you need me again, just let me know.
Thank you.
Okay. Take care. Have a great night, everybody. Good luck.
Bye.
Bye.